Hi, and welcome to the Soluri No Guts, No Glory Hour. I'm Janet.
I'm Vinny.
My husband, Vinny. And tonight we have what I would consider a more serious subject, but nonetheless, it's going to be an enlightening subject. We're going to speak about breast cancer and mastectomies and reconstructive surgery. So it's going to be informative to say the least. But first of all, before we go any further, I just want everybody to know, since I'm speaking from experience, this might get a little emotional. I'm an emotional girl, and sometimes I tend to shed a few tears. So be prepared. If I do, our guest, Dr. Sami Khan, and my husband, Vinny, will pick up the pieces for me until I gather myself back together in the state that I should be. But anyway, first and foremost, this show is going to be dedicated tonight to a dear friend of mine, Lee Cantonese, who passed away, I believe it was 3 years ago. She was a breast cancer survivor. She helped me through my ordeal when I was diagnosed 5 years ago. She read all my reports, which I had many of, and she actually understood a lot of them. And then she accompanied me after I got my first diagnosis from Stony Brook University Medical Center. I had gone to Sloan Kettering, and Lee came with me. She held my hand on the train. We just spoke really openly, and she was a great support. And about a year later, she was diagnosed that she had cancer that metastasized, very hard word to say, and she wound up passing. But the show is for Lee. Love you.
Show goes out to a lot of people. We all have a lot of people it's been touched. My Aunt Sally, Ginny Arceri. I mean, we can go on an hour just naming names, but we got you dear in our heart. The show is dedicated to you. We love you all, and pay attention. We got a lot of knowledge coming up for you.
Right, and before we get into that, because this hour is going to go really fast and there's so much Dr. Khan is going to share with us, I just have to give shout outs to a few people. I have to wear my unfashionable glasses, but here we go. First of all, Dr. Khan, who is my reconstructive doctor, all the girls in his office who I adore and have made my experience just amazing because they're sweet and kind and funny, and we talk about shoes and fashion while I wait for the doctor to come in for the visits. But they would be Janet Trebash, who is Dr. Khan's physician's assistant, and Carol, who is also a physician's assistant there, as well as my good friend Nancy Fenster. Hi, Nance. Oh, we got a call, but we're not going to take that right now. So without further interruption, we have Sandy, Patty, Cindy, Amanda, Michelle, and a special hello and shout out to Nicole. I'm going to say it wrong. Kayaza. How do I pronounce it? Kayaza. She used to be a physician's assistant with Dr. Khan, and since she's moved on to reside in California, where she serves and plays in the sun, as well as still carries on with her work duties. But hi, Nicole, I love you, and I miss you. And also a few shout-outs to survivors who are really important people to me. Cousin Debbie Millette, Kathy Faye, Maria from work. I'm not going to say your last name because you're a little shy, but Maria, my cousin Dee Dee, Lucille Strafer, who is my bosom buddy, and I'll tell you why that is in a moment. Linda Brown. I'm trying to think. I don't think I forgot anybody else, but if I did, I love you guys, and thanks for being here. It means a lot.
No pun intended on the bosom buddy.
Right. Well, no, there is, actually, and I'll explain that. I kept getting prescriptions for mammograms from my OBGYN, and I just stuck them in my pocketbook and never went. And one day I went into work, and my friend and coworker, Lucille Strafer, Lucia, told me she was diagnosed with breast cancer, and I said, wow, I'm a real idiot because it's been 3 years and I've never gone for my mammography. It's pretty stupid. And I told her that day at work I was going to go home and make a phone call that night and schedule my mammography, and I did. And my mom came with me, and we had it done, and I got a phone call to come back in for a sonogram, and right then and there the radiologist came in and read it and told me I had first-stage breast cancer and told the nurse that she should go over with me all the information that I would need to know to go further. So, I sat there stunned and crying, and I drove back to work that day, and I went up to Lucille, and I said, you're my bosom buddy, because if it wasn't for you, who knows maybe where I'd been, where I would have been, because I know I would have neglected my mammographies probably another 3 years. And as we all know, and we'll get to talk with Dr. Khan, you don't know the progression of this disease. So to sit on something and not get a mammography, which is very simple, ladies, is a tragedy. So with that said, I'm 5 years since I've had my mastectomy and my reconstructive surgery, and I'm here to let everybody know that it's not a death sentence, hopefully, if you catch it early enough. So my message, first and foremost, is go for your mammographies annually when you should. Be proactive with your own health, because you know what? You affect so many other lives besides just your own. And a simple thing as being what I've heard some women say is squished in between two cold metal plates of hardware. Big deal, ladies. Try getting a mastectomy or even worse, radiation or chemo. A mammography is nothing compared to that. So be smart, be wise. I hope my words are going to influence you to, from this day forward, make your phone calls. I bug a lot of my friends, emails, text messages, did you make your appointment? And they have, and I've had a few women that actually were diagnosed, and thank God they were saved. So just heed my words, okay? I really mean that. But anyway, I want to introduce our guest tonight, who I adore because he is just a great surgeon and a great person overall, Dr. Sami Khan. Hi, Dr. Khan.
Thank you for having me today.
Thanks for
And
being here.
I'd like to thank all the women out there who unfortunately have been affected by this awful disease, or know someone in their family that's been affected by this. And hopefully what we're going to do today is at least create some awareness and help educate them and or women who have to face this awful disease possibly in the future. But a lot of this is about, and a lot of the national campaigns, the local campaigns, especially this being October, being Breast Cancer Awareness Month. There are a lot of campaigns going on during the month, and the biggest thing that each one of these campaigns hopes to achieve is creating awareness and educating, so we can hopefully detect cancers and hopefully in the future, with future research, develop better therapies and better treatments.
Right, absolutely.
We've come a long way, right?
We definitely have come a long way, both in the treatment of breast cancer and then in my own field, the reconstructive process related to breast reconstruction after breast cancer therapy. And over the last 30 years, there have been a lot of major changes and a lot of advancements, both on the treatment of the cancer side as well as the reconstructive process, and on research and into what causes, what may cause, and future developments in breast cancer therapy.
Mm-hmm. Well, I had asked the last 2 weeks pretty much on Facebook, I kept posting that you were going to be on the show, and everybody knows I'm very open about this. I am not shy, and there is no reason to be shy about this, ladies. My breasts never defined who I was as a person, ever, and anybody who knows me knows that. So, yeah, it's a body part, and we feel sexual with it, but you know what? I feel sexual through my whole process, which is a scary one until you actually know what you're going to go through. So I just want to say, I caught it at a very early stage, so I didn't need chemo or radiation. It hadn't spread through my lymph nodes. But my first thought was, and I'm sure a lot of you women probably have the same thought, oh my God, I am never going to be able to look at myself from the neck down ever again. I'm going to look scarred and like a Frankenstein, and who's going to want me? And I just had so many thoughts running through my head. But you know what? I researched a lot of stuff, and then I found Dr. Khan, who was recommended from Dr. Palmer, who was the mastectomy doctor at Stony Brook. And he was wonderful, and you made my process so easy. And I just want people to know, if I could show you now, no, I can't show you now, but if I could, I've shown a lot of you who are close to me, to show you the work that this man does. You go through a horrible thing, and he makes it just okay. He makes it wonderful. I'm fine, I'm healthy, I'm beautiful, the girls look good, I'm proud to say it, and I'm here to let people know I'm great, right, Vin?
She's good to go.
Let me just, real quick, to get a little funny, what kind of a job did Dr. Khan do?
He's amazing. I'm telling you right now, this guy has got hands of gold. I mean, she's perfect in every way. She's healthy, she's good, she's an advocate for this. You can always contact her if you need to talk about this. Great job.
Yeah,
Great job.
He makes breasts look the best they can possibly look.
Yes,
So if you
he
have to
does.
go through this, you definitely want to look him up and know not to be afraid of it. But anyway, Dr. Khan, I had asked people to send in questions. And by the way, throughout the show, we're going to have a banner on the bottom of the screen that's going to give resource information. There's a lot of resources out there for you ladies, especially the Long Island 2 Day. People ask, well, in general, where does the money go? I give so much money, people give money. I want everybody to know the Long Island 2 Day, their motto is, what's raised here stays here. and there's going to be a number flashing down. You can call them, ladies, if you have any questions. They send people to your house to clean if you're too sick to do so during treatments, car service. There's just a numerous amount of resources. It's just a matter of knowing where to tap into it. So with that said,
It's a great charity.
yeah, I have a lot of questions, so can we just go on one at a time?
Sure, why don't we go to
Okay, and whichever ones
questions
you
that,
can
people
answer,
ask.
Okay, Diane Tazuli, love you,
Love you.
girlfriend, and I
Need
know
a
you're
cookie.
watching. He needs a cookie.
I need a cookie.
Okay, Diane asks, after having a mastectomy, are screenings ever needed again? And if so, how does one get properly screened?
So having a mastectomy significantly reduces the risk of recurrence or spread of the disease. It's treatment for breast cancer, but there, depending on the stage of the cancer when it was caught, there is still risk that there can be a recurrence. And so because of that, continued screening is required, whether you have a mastectomy and no other treatment, or if you have a mastectomy and breast reconstruction. And with the breast reconstruction patients of mine, after they've completed the reconstructive process, I see them minimum on a yearly basis. I also encourage all women who've undergone reconstruction in our office to continue to do self-breast exams monthly. If you've undergone a lumpectomy, it's ever so more important because you still have native breast tissue remaining that has the potential to develop cancer. And so it still is a very important thing. Even with a mastectomy, it's important. Continued follow-up if you underwent chemotherapy with your medical oncologist, follow-up with your breast surgeon. If you underwent reconstructive surgery, then follow-up with your reconstructive surgeon on a yearly basis after you've completed the reconstructive process, and continued self-breast exams. And I think the self-breast exam issue is extremely important. You know, it's your own body. All women should be doing monthly self-breast exams. And you know, what happens is a lot of people forget. They say, oh, I'm too young for this to happen to me. Like you mentioned with the mammograms and the prescriptions. We all, when we're young, we don't think that anything like this could happen to us. And it's ever so more important to self-breast exams when you hit the age for screening mammograms to at least get a baseline screening mammogram, and then based on your individual circumstances are going to be when the recommendations play into when you get follow-up exams.
And the self-breast exam is done how?
So the self-breast exam is done, what we usually recommend is that pick a day of the month, either the first day of the month or the last day of the month. It should just be a consistent time of the month because there's going to be, with hormonal changes through the cycle, there's going to be changes in the breast, and that's normal. So you want to pick a consistent time at each point so you catch the breast at the same point in the cycle and you're able to tell if there's a change. And then if there's any change, any question, no question about anything that a woman has concerns about, a breast, a new lump, something they feel that looks abnormal, it's all important to bring up to your physician, your breast surgeon, your oncologist if you're a former breast cancer patient. It's ever so more important if you're a former breast cancer patient. But the best way for screening is to start with self-breast exams followed by mammography and follow up with your physician.
Is it a certain technique that should be done, or?
Well, there is a technique. It is a palpation. Most women we recommend either in the shower or right after showering, palpating the breast, each breast individually, trapping the tissue between the chest wall and then also in the fingers. Also examining the axilla or your armpit where you have the lymph nodes that are the area where you potentially, up in here. Now, you know, there are little nuances, differences that physicians will recommend. I leave it up to, you know, whoever the primary care physicians, OB-GYNs that are following these women, mostly for screening, to recommend. But the most important thing is that you pick a time consistently each month.
Right, so
to do
stay
it.
on the same day.
Stay on the same
every
day.
month. You know, pick the day you were born. If you're born on the 13th, every 13th, you know, do that. And ask your physician, you know, ask your personal physician how would they do it. You know, maybe some people say go in a circle around, you know, through the fingers, like you were saying. But I guess everybody has their own technique. But it's just good to check and
Right,
ask.
and you know what? Sometimes, like even after all the surgery I've been through and everything, every once in a while I'll feel something, or I had some shooting pains a couple of years ago, and I was hesitant to call your office because I said, I don't want to be one of these like complainers, like, oh, I have a pain. But it reoccurred, and I got nervous, but I didn't want to call because I thought, oh, I don't want to be one of those pain in the neck patients, which I never am, right?
No, you
Tell me I'm
definitely are
not.
not.
Okay. But you know what? Don't feel funny, guys, because, we're not doctors. We don't know. So if you think it could be something, go and get it checked out. And if it's nothing, then, yeah, you leave the office and you're happy and you have celebration, That's good. But you need to go to see if it is something, you need to catch it quick. Okay, next question. Does one have to have a family history of breast cancer to be considered high risk?
Most of the high-risk patients that we see usually have a strong family history, but it doesn't mean that having a strong family history is the only way that that a woman can develop breast cancer. We see numerous women who have no family history that have developed breast cancers, and there's no family history. They don't necessarily have a lot of the risk factors. There are some well-known risk factors that the breast surgeons, the cancer surgeons, have delineated and go through with the patients. The primary care physicians will talk to women about this, but a strong family history raises the risk, and it really gets into the discussion of genetic testing and how does that play. If you have a strong family history, does that mean that you have a high risk of having the BRCA gene? And there is increased risk, but just having a strong family history does not mean that a woman carries the BRCA gene, and that's the genetic testing that we're able to do today. And women who do have that genetic mutation in that gene have an increased risk over their lifetime for development of breast cancer.
Well, with that
Is that the
said,
gene that Angelina Jolie had? Is that?
well, we're going to get into that in a second. But before we go any further, I did forget at the moment when I was mentioning all my girlfriends, a very special friend, Dana Lynn Didio. I met her in a support group when we were first going through this, and I have a story I can't even tell because I can't tell it without crying. It's a miracle story. Dana, you and I know what that story is, so I'm not going to get into it because I'll start the waterworks. But Dana has a question. She's gone through a lot with breast cancer, radiation, and chemo and everything. She says her oncologist says because there's no family history, she's not necessarily a candidate for a mastectomy, but of course she could still do it. But he warns her that she should be prepared for a double mastectomy and a hysterectomy. So she's on the fence whether she should get a mastectomy. But she says she also has an additional concern. How do you have a mammo with implants? She said she had spine surgery when she was 18. She's got a metal rod in her back, stainless steel, not titanium, so she can never, ever have an MRI. She said if she did have a double mastectomy, how could she continue to watch for breast cancer? But I guess we kind of touched on that, right?
We did touch on it a little bit. Some of it is self-breast exam. You can get a mammogram with breast implants.
You can. It makes no difference.
We have thousands and thousands of women who have breast
implants.
augmentation,
Right.
so they have their native breast tissue with the implant, either under the breast tissue or under the muscle. And it is still very important for them if they either have a strong family history or they have a suspicious mass or lump that they feel on self-breast exam to be seen by their physician, or if it's the recommendation of that physician to get a mammography or ultrasound to get it. And with the addition of the implant, there may be some additional views that need to be taken with the mammography to see around the curvature of the implant, to be able to see for the mammographer to see the entire breast tissue. But it is still important. It is able to be done with implants.
Right, so they have.
And they're still at risk, so.
They are still at risk, after you have a mastectomy and you have reconstruction with implants. Usually, most of the screening is done, there's sort of levels of screening. Most of the screening, self-breast exam by your reconstructive surgeon, follow up with your oncologist and exam by them. And on at least 6 months, every 6 months, follow up with the reconstructive surgeon for the implants at a minimum of a yearly basis, as well as your breast surgeon. And then there are other imaging modalities that can be utilized. In her case, because of the spinal surgery that she had, and these are not titanium rods, so there's likely an issue with getting MRI exams, which we're using more and more, and the oncologists and the breast surgeons are using more and more. So in her individual case, there's going to be a potential issue, but their follow-up exam and there are other imaging modalities that can be utilized if need be. Ultrasound, mammography to look at that, and then if there is a suspicious mass, then moving on to even biopsying them.
Okay.
Okay, Dana, I hope that helped you out, and I just want to tell you, you are one strong, brave, courageous woman, and it's a pleasure and an honor to know you and be friends with you. I just wanted to say that. Diane Terzulli, another question she had, do underwire bras contribute in any way to the increase of risk of breast cancer?
So there's no data, scientific data, to say that an underwire bra contributes to it. A lot of women will say and complain that they're extremely irritating, and we see a lot of evidence with the chronic use of them that they can be irritating to the skin, but there's no scientific data
Thank God.
to say that
Just go braless, really, just let them hang.
Keep the cleavage. You hear that, girl?
Oh, I
No
say let them
problem.
go, burn them like in the 60s. Okay. I want to pick the right questions for the right time. Okay. Okay. All right. So you know what? I'm going to go right to this question. Well, it seems that more recently, and we discussed this before in the green room, it seems like there's to me, but I don't know scientific data, there just seems to be an influx of breast cancer. And I don't know if it's centrally located more on Long Island or nationwide, but it just seems like every time I turn around, somebody, and people call me, I guess, because they know I've been through it, so people call me for, support and all that. What's the deal with that?
So I think there are a lot of factors at play here. I think part of it is that here in Long Island we do seem to have some clusters of breast cancer. There are others in the United States, Marin County in California, that have higher incidence of breast cancer in particular than would be expected by population-based studies. What are the reasons why? There have been numerous questions about this. Again, when you look at the scientific data regarding this, probably what's going on is not necessarily any good hard data to say that specific environmental factors in these communities are causing this, but rather if you look at known risk factors, we probably have higher proportions of the population in these high incidence areas like Long Island. Mm-hmm. Risk factors like older age, higher incidence of breast cancer in Caucasian women, a higher incidence of breast cancer in women who have increase in alcohol consumption, higher incidence of breast cancer, or risk factor being later date of pregnancy, of first pregnancy. And so when you look at these known risk factors, probably what's going on in these high incidence areas like Long Island is that we have a higher proportion of the population that has one or maybe numerous of these known risk factors. But there's no data that's shown any environmental factors locally in these communities that are causative of this. And here in Long Island, there's very good data collected over the last 20 years that looked at these specifically and looked at them in a scientific way. And there's no data that to show any causative relationship between those environmental factors.
Okay.
But you say the ratio of people to breast cancer, Long Island's high up there?
Well, I think what I'm saying is that there are some well-established known risk factors, and probably if you looked at the population here, we probably have a higher number of women who have one of those known risk factors.
Okay. Okay.
I have a theory. I told you, again, in the green room, again, no scientific data on it, but I just feel like if you look at life, what it was 40 years ago and what it is now, I mean, when I was a little kid, my mom worked, but everything was so more home-based. We didn't go and eat out and fast food and all that. People cooked it inside. They cooked the old-fashioned way.
Fast food was a treat.
Yeah, it was a treat. It was a big deal. But I think, my own theory, is plastic, I believe, and you don't have to comment on it either way because I know whether you can or, if you want to or not, but I feel like I'm going to stay away from, and I do stay away from plastic, especially heating and plastic, but you think about plastic containers at a Chinese restaurant. Plastic is all chemicals, You get your food, you get a hot container of soup, it's hot. Now, that container, it actually is so soft when you first get it because it like, almost like melts. And I feel like where are those chemicals omitting? They're omitting into your food and, you're ingesting it. Our bodies were not made to, waste out chemicals like that. Your body holds them, they're toxins. But anyway, that's just my theory.
That's another one of Janet's theories.
But just use glass. I mean, if you can help it, just use glass. Cook in glass and kind of ditch the plastics if you can. But now this is a question that our very own Janine Zarilli here in the Madhouse presented to me. Yeah, Janine, and I thought it's a really good question. So here we go. Do you have any thoughts about, and what your opinion may be, if any, on any woman getting a double mastectomy or mastectomy without ever being diagnosed with breast cancer, but may have a family history of it, as, for instance, Miss Angelina Jolie, who brought that to the forefront in the limelight because she's who she is?
Sure. And, when the question is sort of a broad question, and
Janine's a really cool broad. No, I didn't say that.
Since we've discovered these the BRCA genes, it's 2 genes. We know there are a lot of families that have strong family history of breast cancer, but that doesn't include all the women who get breast cancer. We've discovered, or researchers have discovered, these 2 genes that we're able to now test for. And that has really brought this question to the forefront of you don't have a formal cancer, you don't even have any a mass or suspicious mass, but you have this gene that's positive that increases your woman's lifetime risk of developing a breast cancer. And what is that a reasonable thing to undergo a double mastectomy? And if you look at it, it's a little different than a formal cancer, but we know if you test positive for one of these genes, there's a significant lifetime risk of development of breast cancer for these women. And because of that, we feel that it is a reasonable option to have a double mastectomy. I think Angelina Jolie's discussion and revelation that she underwent a bilateral mastectomy followed by bilateral breast reconstruction because of testing positive for the gene. Her mother had breast cancer and died at a relatively young age from breast cancer. This has really brought this discussion out into the open, and it's a great story. What she did. She wrote a very nice, eloquent op-ed article in the New York Times, and really told her story and why she did it, and related to her mother who developed breast cancer and died at a young age, what she was trying to achieve. But what I think it's really done is brought awareness to this, and it's a great story. What we would like to achieve by this story and what she's done is help educate women that about breast cancer, about screening for breast cancer, about treatment for breast cancer, and about even reconstructive options related to breast reconstruction after a mastectomy.
Okay. Yeah, that was a brave thing she did, and the best thing to do is when you're famous, everybody knows you. And she's still a sexy, beautiful woman that changes nothing, ladies. But we have a lot more to talk about, so we're just going to take a quick commercial break, and we'll be right back, so stay tuned. Thanks.
Like so many people, are your finances tight lately? Afraid to open your mail or even answer your phone? Well, take heart. You don't have to live like that. If you're 62 or older and own your own home, you can join the thousands of folks who have used safe and effective government-insured reverse mortgages. The government-insured reverse mortgages from Long Island's Senior Reverse Network allow you to stay in your home and turn equity into tax-free cash. Our government-insured reverse mortgages can eliminate mortgage payments credit card balances, or just improve your lifestyle. Do yourself a favor and solve these problems now. Call the Senior Reverse Network, and our advisors will answer all of your questions about our reverse mortgage programs. We've helped scores of senior Long Island homeowners like you who now enjoy a worry-free retirement. Get the financial security and peace of mind you've dreamed about. Pick up the phone and call us at the Senior Reverse Network now to set up a free consultation.
Call 1-800-985-REVERSE. That's 1-800-985-7383.
On Saturday night, October 19th, Act One Entertainment Net coordinates 6 Long Island venues with over 30 bands that will participate in Banding Together Against Animal Abuse, a fundraising event benefiting Save a Pet Rescue and Adoption Center in Port Jeff. Hosting these simultaneous multi-venue unique events will be the Blue Parrot Lounge in Massapequa, Candy's Magic Pub in Shirley, Grumpy Jack's in Port Jeff, Bobby Q in Patchogue, Hotel Fish in Hampton Bays, and The Hub in Island Park. For more info, call the Act One office at 631-758-3505.
Hi, and we're back, and I want to thank everybody for staying tuned, and I want to say hello to Kim Eric, my friend at work, and my friend outside of work. Kim, I love you, and you're a survivor as well, and you're beautiful and strong, and I'm giving you a shout-out, girl. I love you. We have a friend, Carl Wiggins. Hi, Carl, who lives in Croxley Green, London, and he sent me 2 photos today of these lads in his hometown that actually, I need my glasses to read this. Let's see. One of the guys' names is Kyle, but all 3 of these gentlemen work at the Fountain Workshop. In the project they're working on happens to be in King's Cross, London. And Janine's going to show us these 2 pictures because these guys support breast cancer.
But before we go to that, I want to thank Carl. He's over there in England, and he supports us. He watches every show. He gets people to watch our show. He's a big influence. He writes a column in the Copeg Weekly. He writes books. I mean, he's an amazing guy.
He's a great author. Yeah, we want to thank you,
I
Carl.
just want to say cheers. I love you, mate. You know you're my brother forever.
Okay, Janine, so we're going to show these 2 pictures. This is the guys from the back, and their boss, whoever owns the company, was generous and kind and caring enough. The company, again, is called the Fountain Workshop. So the boss provides them with this attire for the whole month of October, the pink hard hats and the vests. And I just want to give a shout out to you guys because I heard you guys from London were going to be watching. Thank you guys. Thank your boss for us. Thank you for bringing the awareness. You guys are adorable too, and you're rocking those vests and hard hats.
Awesome.
So I love it, but I want to say thank you. Now we have a question from a good friend who always supports us as well and watches, Michelle Sapienza Lentino. Hi, Michelle. Michelle's question, Dr. Khan, is, are we any closer to learning of a cure? With all the money and the awareness that has gone into breast cancer, much more recent, inundated everywhere you go. Breast cancer, fundraisers.
No, that's a great question. And, you talked about awareness, and I think a lot of the national campaigns and local campaigns that are going on, again, this is October, this is Breast Cancer Awareness Month. On October 16th, just a couple days ago, the American Society of Plastic Surgeons had Bra Day. Bra Day is Breast Reconstruction Awareness Day. So it's a national campaign. There were over 150 events nationally in different communities associated with Bra Day. That's our National Plastic Surgery Society that is heavily invested, along with the Plastic Surgery Foundation, which is our national research foundation, in raising awareness, increasing access for women to treatment for breast cancer, in particular reconstructive surgery related to breast cancer therapy, and promoting education and research. And there has been a lot of money raised. I think the data that we have in the fact that we're diagnosing breast cancers earlier and earlier, our survival rates have improved if you look over the last 40 years because we're catching these cancers a lot earlier with better screening methods. There's a lot of money that's raised by a number of different great organizations. Again, I mentioned those two. Locally, we have the Carol Baldwin Breast Center at Stony Brook, which has a number of philanthropic events yearly, raising over $250,000 that is all put towards breast cancer research and funding breast cancer research. So I think with this funding, we definitely are making headways. We've improved screening techniques. We've improved the surgical treatment of breast cancer. We've improved in the options and the outcomes for breast reconstruction. And so there has been a lot of money, and it's not an overnight thing, and we need to continue to raise money to fund research, to improve access, and to create awareness for breast cancer for women, so we can hopefully one day work towards that goal.
Right.
Awesome.
Good.
Thanks, Mo. Good question.
I did do the Long Island 2-day walk 2 years ago, and it's a walk. I think it consists of 38 miles over the course of 2 days, and I was in shape. I work out and everything, and I'm a skater. And my team, because you get onto teams, they were walking every night, and increasing their mileage every night. And I just didn't have the time because I was involved in so many other things. But I thought, I could do this. This is no big deal. It's walking, Oh my God, by the time we got through the first phase, the first day, I thought like the last 5 miles I was going to die. My butt hurt so bad. The last station that we stopped, because there's always stations along the way that give you oranges and water and ice. I took 2 ice packs and stuck them in my pockets and my shorts. I almost really couldn't make it.
And I got like the best sneakers, the best socks.
He got me the best of everything.
But I knew it was going to be rough, but she, like I said, she's a beast.
A lot of women had blisters. I didn't have blisters because he provided me with good footwear and stuff. But ladies, if you could do the walk, so what? Your legs hurt a little bit. You need ice packs in your butt. Just go out and support. You can even support that walk by helping volunteering. There's so many different ways you can volunteer. But I just want to thank Diane Terzulli and all my friends at work also. I almost forgot to say this. 2 years ago when I did the walk, you guys helped raise almost $1,000 for me to go towards a contribution for my team. And I thank you guys for that. It really meant so much. And Diane Terzulli headed that up. And she takes charge no matter what she does. And she takes charge and gets the job done. And Diane, I just want to personally tell you now, where everybody can hear it, that I thank you for that. It meant a lot to me.
And it's not just this month. They could donate all year round,
All year
right?
round. And there's so many different ways. If you go to the numbers that Janine and Vicki are putting down on the bottom of the screen tonight, go all those places. If you have some free time, it doesn't even have to be on a regular basis. See what you can do to help, or even drive somebody to a treatment or whatever it is. They can direct you with that. Can we talk a little bit about, I don't know if you can, we didn't talk about this prior, so if you can't, I understand, the process of reconstructive surgery? I mean, I'm going to tell you what I thought of it as, but then I don't know if you can, really get into what it's.
I mean, we can talk a little bit about, in general terms, about the different options, and it is a process. It's not a one day or a overnight thing.
That's what I was going to
It's an entire process that goes into this. There's a lot of team members, and this is a great point, that the treatment of breast cancer is really improved by a team-based approach. And this is something that we really feel strongly about, both at Stony Brook Medicine as well as the American Society of Plastic Surgeons, our national society, that a team-based approach to the treatment of breast cancer is the best way to improve outcomes for women who are unfortunately going through this awful disease. And this involves numerous different medical professionals. It involves physical therapists, nurses. It involves not just the treatment of the cancer or the reconstructive process. It involves helping women navigate systems, helping them to live through live through this, helping their families to cope with this. It involves psychologists, psychiatrists. It's a whole team of professionals who are there to help women navigate the process and to achieve the best outcomes that we can for them.
Mm-hmm. Again, my mind's always thinking, and you know this because since the day I came into your office the first time I met you, I always come in with a list of questions, right? I always do, because I'm so inquisitive and so many things pop into my mind. When I first knew that this is the route I had to go, I just thought that I'm going to be really candid, but I just thought that you just like cut them off. I couldn't even imagine what to expect, you know? That's why I thought, oh my God, this is going to look horrific. I'm, not going to be able to look at myself, which is so not the case. But then I try to tell my friends, not really knowing the procedure exactly, I look at it as your breast being an orange, and pretty much all the tissue has to come out. So I pictured it as an orange or a melon, depending on who you are. But to actually get in there and scoop out all the breast tissue and take it out, and then what they do is they put, that's what what Dr. Palmer was actually considered, what kind of doctor is that called?
She's a surgical oncologist who specializes and focuses on breast cancer.
Right, she's the one that takes out all the breast tissue
She's
and
the
all that.
scooper.
So she does. She's the surgeon who performs, and the surgical oncologists or the breast surgeons are the surgeons who perform lumpectomies. They perform a lot of the biopsies
Right, yes, she had done
for
my
masses
biopsies,
or
yeah.
lumps. They perform the mastectomies, or if you hear about things like axillary dissections. These are all the procedures that go into the actual surgical treatment of the cancer itself, and these are performed by the surgical oncologist or a breast surgeon.
Right, and then you, a doctor of plastic surgery and reconstruction, come in, and then for my particular case, because I know everybody's different, Dr. Khan came in and when Dr. Palmer was done, and he put in expanders, because now is it because you have to, because I know people want to know the process. Sure. It's to slowly stretch the skin because it can't accommodate implants all at once, is that?
Well, and again, we'll touch on a couple points that show where things are headed as far as breast reconstruction, but there are two broad categories for breast reconstruction. They're based off of two things. One, how are you going to reconstruct, or what are you going to utilize to reconstruct the tissue? Because you're left after a mastectomy with a deficiency of the volume of the breast tissue, and you're left with usually a loss of skin or a skin deficiency. So how are you going to overcome these two deficiencies now to reconstruct the breast? And the other broad category that you can divide breast reconstruction is based off of the timing. What's called immediate reconstruction or delayed reconstruction. Immediate reconstruction being reconstruction done, or the process is at least started the day of the mastectomy. Delayed reconstruction is you undergo mastectomy and you go through any treatment that you may need, and then at a later date you start the reconstructive process. And if you look at trends over time, 25, 30 years ago, it was probably 20%, 25% of women underwent immediate reconstruction. 75% underwent delayed reconstruction. Now today, if you look at national numbers in the United States, we've reversed those numbers. And we now have about 75% of women undergoing immediate reconstruction and 25% undergoing delayed reconstruction. There are medical reasons as to why a woman would possibly need delayed reconstruction. Mm-hmm. Some of it is access issues. We're working, a lot of our national educational and even local educational programs at Stony Brook Medicine are trying to educate women and trying to improve the access to that. And there are a lot of national education programs that are going on to try to improve that. There are some medical reasons as to why a woman would need to go to have a delayed reconstruction. I think the freestand or the comprehensive breast centers, like the Carol Baldwin Breast Center at Stony Brook Medicine, these are multidisciplinary, team-based approach teams that approach breast cancer therapy and breast reconstruction and involve both the breast surgeons, the oncologists, the reconstructive surgeons. And I think these are really good centers that allow a woman to come to one center and see everything from the diagnosis to the treatment of the cancer to the reconstructive process all in one place under one roof, and promote this team-based approach to improve outcomes.
No, Carol Baldwin Center, they were great there as well. All the women were great that I dealt with. I spent a lot of time there, and all my tests, and they were just so wonderful. I mean, the whole process, for me, I actually, I'm not going to say I enjoyed it, but I mean, it was, I don't want to say pleasurable either. I don't want to make this sound wrong, but it was just an easy thing for me, guys. Everybody made it so wonderful.
I wanted to ask you something.
Sure.
Are men at risk of breast cancer?
So there is the entity of male breast cancer. So men are at risk. There are, some families. I have patients, male patients who had breast cancer who have a family history of it. The issue with male breast cancer is it doesn't receive as much breast time, so it's not as well known. Even more so in men is the stigmata of quote, breast cancer.
Exactly.
And so a lot of men present at a later stage, and because they present at a later stage, we're treating these at a later stage, and sometimes the outcomes are not as good because it tends to be a later stage presentation for a number of reasons. But a lot of it is that most men don't even think that it's a possibility.
Right.
If they
sad,
feel
actually.
something in their chest or their breast, they don't necessarily go beyond that to let their physician know.
They think they got a
or to
new
get
muscle.
screened. Correct. I wanted to touch on one thing. You talked about the different types of reconstruction. There's both the implant or expander implant-based alloplastic breast reconstruction, as we call it, and then the tissue-based reconstructions, and that's the flaps, what we call flaps.
Right, yeah.
And that, they're pedicle flaps, they're the free tram flaps, and now the free perforator flaps from the abdomen. They're perforator flaps from the inner or outer thigh. The most common are the abdominally based flaps, and these are lengthy procedures. The flap procedures, they're longer than the expander implant based reconstructions. And really, what it is there's more than one option. One option may be better for a woman, or maybe better to achieve her goals. And it's really creating a team that has reconstructive surgeons who are able to offer women any type of reconstruction that's out there. And then taking the individual characteristics, goals, and desires of each woman, and creating a tailor-made reconstructive process to achieve her outcomes, her goals, and really individualizing that rather than having a cookie-cutter based approach where I do this type of reconstruction and I'm going to do that in every woman.
Right,
It's really,
right. You
really
tailor-
individualizing
right,
the treatment or the reconstructive process.
Everybody's different, right? So
Yeah, and the flap is, because I had read so much, when I was going through my stuff, you take, well, can you say that? I'm not going to explain it correctly, so it needs
So
to
you're
be-
transferring tissue. It's going to be skin and fat, sometimes muscle, and transferring it from the abdomen or from the back or from the inner thigh to the breast in the free or microvascular reconstructions like the perforator flaps and the free tram flaps. It's hooking it up to an artery and vein and using your own tissue to recreate and overcome that deficiency in skin and the deficiency
My
in
cousin had
volume
that done,
that
yeah.
you have from the mastectomy and recreating that. And again, there are pros and cons to each type of procedure. It's really sitting down with a woman before she undergoes a mastectomy, talking about the options, talking about what her goals are, talking about what her individual body characteristics are, talking about each of the procedures and the pros and cons, and really educating women about the fact that there are options, there's more than one option, and creating an individualized treatment specifically for her.
Yeah, when you put the, I like to get a little funny sometimes, but when you put the expanders in, well, actually, I didn't know what to expect when I woke up after the surgery, I guess, and you really couldn't say until you were in there, right, and doing what you were doing. And I woke up, and you were able to inflate me. I don't know what the term would call, but you put the expanders in, and they're almost like an implant, I guess, sort of, but they're not the actual implant. And again, it's to stretch the skin in order to accommodate when the implants are going to go in. And I remember the next day you came in and you took the bandages off, and I was telling myself the whole time before all this, there's no way I'm going to be able to look down and see. Well, you took the bandages off, and I was like, wow, that is so cool. and I had a little breastage going on there. And then the first time I had to go into your office, what they do is they slowly expand them, ladies, and they inject saline, is it?
It's saline that's injected.
Saline,
yes.
just to start stretching the skin out. And I'll never forget the first time I came into your office for the office expansion. I was on the table, and I forget who was actually doing it. It may have been Nicole, I don't even know. And I said, is it me? Or I felt like a cartoon, like I felt them going, like I could feel them getting bigger. And she goes, no, they're getting bigger. And I couldn't wait to get out of the office. And my girlfriend Mary Ann lived like 5 minutes from your office. And I flew to her house. I ran right past her, ran through the door, ran to her bathroom to look in the mirror. I said, I just got to see what these look like, because I actually felt them like a cartoon, just getting bigger. And I just thought it's just the coolest process, you know? I mean, if you go into it, of course, with, knowing in your heart that your surgeon's going to be good and he's going to do right by you and feeling confident in that, which I did. And the process is actually pretty cool, because the medical world, it's amazing what can be done, And every time I went back to the office, they would slowly expand them a little more, and then when they get to where you want them, where they should be, whatever, go into the operating room again. They're taken out, removed,
Yeah.
and then you go and put the implants in, and then for me, that was pretty much it. I know everybody's different, but it was. I just found it fascinating. I found the whole process fascinating.
Yeah, and we've been fortunate over the last 3 decades. We've had major advancements in the safety and the quality of breast implants that are available, both silicone and saline implants. We have better and better techniques at autologous reconstruction using your own tissue. We're starting to do more and more nipple-sparing mastectomies in certain groups of women. And starting to do more and more even direct-to-implant reconstructions, and again, in certain women. So it's having the ability to offer each one of these options, knowing the characteristics of each woman, knowing her goals, and figuring out with her as part of the process, and really as part of the team. And it gets back to that concept of the team-based approach, and each one of these women is part of the team. She's the most important person.
Right.
Now, the leader of the team.
She's the leader of the team.
Nipple sparing, because when I went to Sloan for my second opinion, that doctor there said, I think you'd be a good candidate. And then when I came back and discussed it with Dr. Palmer again, she just said, absolutely not. But then that's me, and that was 5 years ago, so I don't know if a lot of things changed. But, I mean, I was told that, there still could be one cell in there that could carry it. So if they don't take the nipple, you could go through all this, and maybe 5-10 years down the road, whatever it may be, it could reoccur. But that could be regardless, right?
And this is really a discussion that we leave for the woman to have with their breast surgeon.
Okay.
There is a risk. Some of the highest concentration of ductal tissue is in the areola. So there are risks of recurrence with leaving the nipple. But there are definitely, over the last 5-6 years, we've made a lot of major advancements in nipple-sparing mastectomies. And it's really studying and looking at who are good candidates, what group of women are good candidates. And a woman may be a candidate for a number of different reconstructive techniques. So we really need to sit down, have a discussion, an open discussion about what the techniques are, and then what an individual woman's goals are, and really tailor the reconstructive process to her.
Right. And that makes sense. I mean, we're all different, and I guess the disease is different in so many ways too, right? So it all depends. We're going to take one more commercial break real quick, and then we're going to come back. So stay tuned. Thanks.
This is Beth.
Hi.
Oh, congratulations. When are you due?
I'm not pregnant.
Oh, look at that. Excuse me.
You're totally thin.
You look very sexy.
For life's bleachable moments, all it takes is 3/4 cup.
For professional motorcycle transport and towing, think Kickstart Fabrications Motorcycle Towing. Proudly serving all of Long Island, we feature expert handling and 24/7 service. So send a limo for your toy with Kickstart Fabrications Motorcycle Towing.
And we're back. And we only have about 4 minutes left, and there was just so much to talk about and never enough time. And I want to thank Dr. Khan again. But I know you have some things you want to share with everybody. Some
Sure.
resources.
No, there's some resources that I'd like to share with women or their families that have questions about this or seeking information about this. Again, the most important thing that I want to get across is this is about creating awareness. This is about educating women and their loved ones about the process and letting them know that there are options and different options for breast reconstruction. If you want more information on a national level, the American Society of Plastic Surgeons website is plasticsurgery.org. The BRA Day, which I mentioned, Breast Reconstruction Awareness Day, brausa.org. Locally here at Stony Brook Medicine, this Sunday is the Walk for Beauty. This is the 20th year that Stony Brook Medicine is sponsoring this. It's a great event, raises a lot of money that's then used by the Carol Baldwin Breast Center for funding research into breast cancer and breast cancer therapies and reconstructive processes. And then on Tuesday from 6 to 9 p.m. at Stony Brook Medicine at the Wong Center on the campus is a community outreach program where there'll be myself, I'm going to be speaking on perforator flaps and the evolution of them, as well as Dr. Brian O'Hay, who's the director of the Baldwin Breast Center, and a number of other medical professionals speaking on issues related to breast cancer and breast cancer therapy.
Very good, thank you. And there's two women I just want to recognize tonight before we go and say goodbye, is Linda Billy. And Linda Billy is, what's her title exactly?
Well, Linda Billy is one of the cancer liaisons at Stony Brook, in particular related to breast cancer. She also every year organizes a fall fashion show, which was last night at Villa Lombardi's. And you get to come see some of us who are part of the breast cancer therapy team get up and walk down the catwalk, and you
great.
can hoot and holler and make fun of us if you want. But it's a great event, and it really is about honoring our survivors and our patients.
All right. Well, I was at one of those shows probably about 3 or 4 years ago. You were great. You were the best model up there. So, and you were my doctor, so I was cheering you on. I also want to thank Susan Schulman, who handles the communications for the Long Island 2-Day. And you can find them at info@longisland2daywalk.org or the Adelphi New York statewide breast cancer hotline and support program, and their number there is 800-877-8077. And if you're not on Long Island, just go Google cancer, and then there's usually a branch that you can find that lists all the different cancers. Click on breast cancer, and you will find local resources in your town. They're out there in every town, in every city in this country. So reach out. And you can find me on Facebook, Janet Spallone Soluri. If anybody out there has a question, you want to meet up, I meet with women, I talk to them, I comfort them, I show them my surgery, whatever it takes, ladies. Support each other, get your mammograms, stay current on it, and if you have to go through this, just have confidence and faith and know that life is great. So be strong, ladies. We're strong. We're tough. So I just want to thank Dr. Sami Khan again. Thank you so much. And all the girls in Dr. Khan's office. I love you girls. You've made it easy. To Vinny, thank you for always supporting me through everything I've been through.
You're welcome.
And everybody have a great, safe, and happy weekend.
Thanks to all our
Love you.
friends
Thanks
and
for watching.
family that support us. See you next Friday.
Ciao.
Thank you.